Hello, and welcome to another chapter of Advanced Pharmacology. Today we're talking about Chapter 17. Chapter 17 is drugs for Parkinson's disease. Parkinson's disease, or PD, is a slowly progressive neurodegenerative disorder that afflicts more than 1 million Americans, making it second only to Alzheimer's disease as the most common degenerative disease of neurons. Cardinal symptoms are tremors, rigidity, postural instability, and a slowed movement. In addition to these motor symptoms, most patients also experience a non-motor symptom, especially autonomic disturbances, sleep disturbances, depression, psychosis, and dementia. Years before functional impairments start to develop, patients may experience early symptoms of PD, including the loss of smell, excessive salivation, clumsiness of the hands, worsening of the handwriting, bothersome tremors, slower gait, and a reduced voice volume. Symptoms first appear in middle-aged and progress relentlessly. The underlying cause of the motor symptoms is the loss of dopaminergic neurons in the substantia nigra. Although there is no cure for motor symptoms, drug therapy can help maintain a functional mobility for the years and can therefore substantially prolong the quality of life and the expected life expectancy. So, the pathophysiology that underlies the motor symptoms can result from damage to the extrapyramidal system, a complex neuronal network that helps regulate the movement. When extrapyramidal functions are disrupted, dyskinesias, or the disorders of movement, can result. The dyskinesias that characterize PD are tremors at rest, rigidity, again, postural instability, and bradykinesia. In severe PD cases, bradykinesia may progress to akinesia, which is the complete absence of movement rather than the slowed movement. In people with PD, neurotransmission is disrupted primarily in the brain's striatum. A simplified model of striatal neurotransmission is depicted in the following figure. As indicated, proper function of the striatum requires a balance between the two neurotransmitters, your dopamine and your acetylcholine. Dopamine is an inhibitory transmitter, acetylcholine an excitatory. The neurons that release dopamine inhibit neurons that release gamma-aminobutyric acid, or GABA, another inhibitory transmitter. In contrast, the neurons that release acetylcholine excite the neurons that release GABA. Movement is normal when the inhibitory influence of dopamine and the excitatory influence of acetylcholine are in balance. In PD, there is an imbalance between dopamine and acetylcholine in the striatum. As noted, the imbalance results from the degeneration of the neurons in the substantia nigra that supply dopamine to the striatum. In the absence of dopamine, the excitatory influence of acetylcholine goes unopposed, causing excessive stimulation of the neurons that release GABA. Overactivity of these GABAergic neurons contributes to the motor symptoms that characterize PD. That said, between 70 and 80% of neurons must be lost before PD becomes clinically recognizable. Because this loss can take place over 5 to 20 years, neuronal degeneration begins long before the overt motor symptoms start to appear. So again, here you take a comparison look of a normal model of a neuron transmitter versus one that has Parkinson's disease. What causes degeneration of the dopaminergic neuron, therefore? No one truly can understand it, and no one truly knows for sure. However, some evidence strongly implicates that the alpha-synuclein, a potentially toxic protein synthesized by dopaminergic neurons. Under normal conditions, your alpha-synuclein is rapidly degraded. As a result, it doesn't accumulate and no harm occurs. Degradation of alpha-synuclein requires two other proteins, parkin and ubiquitin. If any of these proteins, your alpha-synuclein, parkin, or ubiquitin, is defective, the degradation of your alpha-synuclein cannot take place. When that occurs, alpha-synuclein accumulates inside the cell, forming a neurotoxic fibril. During autopsies, these fibrils are visible as Lewy bodies, which are characteristic of PD pathology. Failure to degrade alpha-synuclein appears to result from two causes: the genetic vulnerability and toxins in the environment. Defective genes coding for all three proteins have been found in families with inherited forms of PD. In people with PD that is not inherited, environmental toxins may explain the inability to degrade your alpha-synuclein. As discussed in Chapter 24, movement disorders similar to those of PD can occur as side effects of antipsychotic drugs. These dyskinesias, which are referred to as extrapyramidal side effects, result from a blockade of dopamine receptors in the striatum. This drug-induced Parkinsonism can be managed with some drugs that are used to treat PD. So, our overview of our motor symptom management. The therapeutic goal. Ideally, treatment would reverse neuronal degeneration, or at least prevent further degeneration, and control symptoms. Unfortunately, the ideal treatment doesn't exist. We have no drugs that can prevent neuronal damage or reverse the damage that has already occurred. Drugs can only provide symptomatic relief. They do not cure PD. Furthermore, there is no convincing proof that any current drug therapy can delay disease progression. Therefore, the goal of pharmacologic therapy is to simply improve the patient's ability to carry out activities of daily living. Drug selection and their dosages are determined by the extent of which PD interferes with their work, walking, dressing, eating, bathing, and pretty much any other form of ADL. Drugs benefit the patients primarily by improving the bradykinesia, gait disturbances, and postural instability. Tremor and rigidity, although disturbing, are less disabling. So what kind of drugs are employed? Given the neurochemical basis of Parkinsonism, too little striatal dopamine and too much acetylcholine, the approach to treatment is obvious. Give drugs that can restore the functional balance between dopamine and acetylcholine. To accomplish this, two types of drugs are being used: your dopaminergic agents and your anticholinergic agents. Of the two groups, the dopaminergic agents are by far the more widely employed. So the following table here shows the dopaminergic drugs that act by several mechanisms. Your levodopa is converted to dopamine, which activates dopamine receptors directly. The inhibition of the monoamine oxidase B, or MAO-B, prevents the dopamine breakdown. Amantadine promotes dopamine release, and the inhibitors of catechol-O methyltransferase, or COMT, enhance the effects of levodopa by blocking its degradation. So here is an excellent spot to hit pause if you're unfamiliar with dopaminergic agents that we utilize for Parkinson's disease. So, in contrast to dopaminergic drugs, which act by multiple mechanisms, all of the anticholinergic agents share the same mechanism: blockade of muscarinic receptors in the striatum. So, what are the clinical guidelines? The management of PD is generally under the guidance of a neurologist who oversees the pharmacologic management. Other providers are responsible for differing aspects of care, including the management of primary care needs and the monitoring of a patient's status. Therefore, it is important for all the providers involved in the care of a familiarity of drugs used to manage PD. The American Academy of Neurology has developed a set of evidence-based guidelines for the treatment of PD and the management of individual manifestations of the disease. The recommendations that follow are based on these guidelines. A lifespan consideration are summarized in a patient-centered care, which is where we'll be starting off next. Drugs for Parkinson's disease, a patient-centered care across the lifespan. Again, it's an excellent spot to Hip pause because there is juvenile PD, as well as what could occur if a patient is pregnant, breastfeeding, and then again your older adult. So let's start with drug selection. The initial treatment. For patients with mild symptoms, treatment can begin with a MAO-B inhibitor. MAO-B inhibitors confer mild symptomatic benefits. For patients with more severe symptoms, treatment should begin with either levodopa combined with carbidopa or a dopamine agonist. Levodopa is more effective than a dopamine agonist, but long-term use does carry a high risk for disabling dyskinesias. Therefore, the choice must be tailored to the patient. If improving motor function is the primary objective, then levodopa is preferred. However, if drug-inducing dyskinesias are a primary concern, then a dopamine agonist would be the preferred route. Management of motor fluctuations. Long-term treatment with levodopa or dopamine agonists is associated with two types of motor fluctuations: the off times, which is the loss of symptom relief, and drug-induced dyskinesias. Off times can be reduced with three types of drugs: your dopamine agonists, your COMT inhibitors, and the MAO-B inhibitors. Evidence of efficacy is strongest again for entacapone, which is a COMT inhibitor, and razogeline, which is a MAO-B inhibitor. The only drug recommended for dyskinesias currently are amantadine. So let's start off by talking about neuroprotection, therefore. To date, again, there is no definitive proof that any drug can protect against the dopaminergic neurons from their progressive degeneration. However, although no drug has yet been approved to provide neuroprotective effects for people with PD, studies do suggest that some drugs are promising. An example of this is the MAO-B inhibitor, which have provided neuroprotective effects in animal studies. Similarly, dopamine agonists have demonstrated neuroprotective effects in your laboratory studies. For both drug categories, clinical studies in humans have been inconclusive rather. A growing body of research with levodopa supports a likely role for neuroprotection. However, because some studies demonstrate toxic effects in patients with PD, the risk still outweighs the benefit when given for this purpose. So, pharmacology of the drugs used for the motor symptoms. Again, now we're strictly speaking motor symptoms. Levodopa. Levodopa was first introduced in the 1960s and has been the cornerstone of PD treatment ever since. Unfortunately, although the drug is highly effective, its benefits diminish over time and its effectiveness starts to decrease over time. So in the use of levodopa in Parkinson's disease, its beneficial effects include levodopa is the most effective drug for PD. At the beginning of treatment, about 75% of patients experience a 50% reduction in symptom severity. Levodopa is so effective, in fact, that a diagnosis of PD should be questioned if a patient fails to respond. Full therapeutic responses may take several months to develop. Consequently, although the effects of levodopa can be significant, patients should not expect immediate improvement. Rather, they should be informed that the beneficial effects are likely to increase steadily over the first few months. In contrast to the dramatic improvement seen during the initial therapy, long-term therapy with levodopa has been disappointing. Although symptoms may be well controlled during the first 2 years of treatment, by the end of year 5, ability to function may deteriorate to pre-treatment levels. This probably reflects disease progression and not so much the development of tolerance to levodopa. The acute loss of effect, therefore. Acute loss of effect occurs in two patterns. There's either the gradual loss over the years or an abrupt loss. Gradual loss or wearing off develops near the end of the dosing interval and simply indicates that the drug levels have declined to a subtherapeutic value. Wearing off can be minimized in three ways: shortening the dosing intervals, giving a drug that prolongs levodopa's plasma half-life, such as your entacapone, and by giving a direct-acting dopamine agonist. An abrupt loss of effect often refers to as the on-off phenomenon, which can occur at any time during the dosing interval. Even while drug levels are considered high, off times may still last from minutes to hours. Over the course of treatment, off periods are likely to increase in both the intensity and frequency. Drugs that can help reduce the off times are listed here in the following table. And as discussed later, avoiding high protein meals may also help with this issue. So here's an excellent spot to hit pause so you can look at all the medications that may, cause more complications of levodopa therapy and trigger that off time. The mechanism of action. Levodopa reduces the symptoms by increasing dopamine synthesis in the striatum. Levodopa enters the brain through an active transport system that carries it across the blood-brain barrier. When in the brain, the drug undergoes uptake into the remaining dopaminergic nerve terminals that remain in the striatum. After uptake, levodopa, which has no direct effects of its own, is converted to dopamine, its active form. As an active dopamine, levodopa helps restore a proper balance between dopamine and acetylcholine. So here is a picture of the steps to alteration of CNS function of levodopa. The conversion of levodopa to dopamine is depicted here in this following figure. As indicated, the enzyme that catalyzes the reaction is called the decarboxylase because it removes the carboxyl group from levodopa. The activity of decarboxylases is enhanced by pyridoxine or vitamin B6. In here, you're taking a look at a picture of the conversion of levodopa to dopamine. Again, that decarboxylase that's present in the brain, liver, and intestines. So why is PD treatment with levodopa and not with dopamine itself? There are two reasons. First, dopamine cannot cross the blood-brain barrier. As noted, levodopa crosses the barrier by means of an active transport system, a system that does not transport dopamine. Secondly, dopamine has such a short half-life in the blood that it would be impractical to use even if it could cross the blood-brain barrier. So, the pharmacokinetics. Levodopa is administered orally and undergoes a rapid absorption from the small intestine. Food delays absorption by slowing the gastric emptying. Furthermore, because neutral amino acids compete with levodopa for intestinal absorption and for the transport across the blood-brain barrier as well, high-protein foods will reduce therapeutic effects. Only a small fraction of each dose truly reaches the brain. Most is metabolized in the periphery, primarily by a decarboxylase enzyme, and to a lesser extent by the COMT. Peripheral decarboxylases convert levodopa into dopamine, an active metabolite. In contrast, COMT converts levodopa into an inactive metabolite. Like the enzymes that decarboxylate levodopa within the brain, periphery decarboxylases work faster in the presence of pyridoxine. Because of peripheral metabolism, less than 2% of each dose enters the brain if levodopa is given alone. Fortunately, levodopa is now available only in combo drugs with either carbidopa or carbidopa and entacapone. These additional agents decrease the amount of decarboxylation in the periphery so that more of the drug can enter the central nervous system. This is discussed in greater detail later in this chapter, so we'll get to that. So, adverse effects, patient education. So that expectations can be realistic, it's important that we inform our patients that the benefit of levodopa may be delayed for weeks to months. This knowledge will facilitate adherence. By forewarning patients about the possible abrupt loss of therapeutic effects during the off times, and to instruct them to notify the prescriber when they occur, avoiding high protein meals may also help. Inform patients that nausea and vomiting can be reduced by taking levodopa with food. Instruct patients to notify the prescriber if nausea and vomiting persists or has become severe. Counsel your patients about the possible levodopa-induced movement disorders. Again, the tremor, your dystonic movement, and twitching. And instruct them to make an appointment to follow up if these start to develop. Inform patients about the signs of excessive cardiac stimulation, any possible palpitations, tachycardia, or irregular heartbeat, and instruct them to notify the prescriber if those start to occur. Explain that hypotension with associated dizziness and lightheadedness may also occur. It's important for patients to move slowly when sitting up or standing up, and, and instruct them to sit down or lie down if symptoms of hypotension, dizziness, and lightheadedness occur. Finally, inform your patients about the possible levodopa-induced psychosis due to visual hallucinations, vivid dreaming, and paranoia, and instruct them to seek medical attention if these start to begin. Most of the side effects of levodopa are truly dose-dependent. Your older patient who are the primary users of levodopa are especially sensitive already to these adverse effects. So speaking on nausea and vomiting specifically, most patients experience nausea and vomiting early in their treatment. The cause is the activation of dopamine receptors in the chemoreceptor trigger zone, or CTZ, of the medulla. Nausea and vomiting, therefore, can be reduced by the administering levodopa in a low initial dose and along with meals. Again, because food delays that levodopa absorption, which causes a decrease in the peak plasma drug level and the corresponding decrease in the stimulation, therefore in the chemoreceptor trigger zone, again, that's CTZ. However, because the administration with food can reduce the therapeutic effects by decreasing levodopa absorption, the administration with meals should generally be avoided. So it all depends on your patient whether or not they can deal with the nausea and vomiting or not. Again, giving additional carbidopa without the levodopa also can reduce the nausea and vomiting. So why carbidopa helps this, triggering of or lack of triggering of nausea and vomiting is still currently unknown. Dyskinesias. Ironically, levodopa, which is given to alleviate movement disorders, can cause movement disorders in patients as well. About 80% develop involuntary movements within the first year. Some dyskinesias are just annoying, head bobbing, tics, grimacing, whereas others can be disabling, balismus, a rapid involuntary jerking or flinging of paroxysmal muscle groups, or chorioathetosis, a slow involuntary writhing movement. These dyskinesias develop just before or soon after optimal levodopa dosage has been achieved. Dyskinesias can be managed in three ways. First, the dosage of levodopa can be reduced. However, dosage reduction may allow PD symptoms to reemerge. Second, we can give amantadine, which can reduce dyskinesias in some patients. If these measures fail, the remaining options are usually surgery and electrical stimulation. Our cardiovascular effects. Postural hypotension is common early in treatment. The underlying mechanism is unknown. However, hypotension can be reduced by increasing the intake of salt and water. An alpha-adrenergic agonist can help as well. The conversion of levodopa to dopamine in the periphery can produce excessive activation of beta-1 receptors in the heart. This arrhythmias can result, especially in patients who have heart disease. Psychosis. Psychosis develops in 20% of patients. Prominent symptoms are visual hallucinations, vivid dreams or nightmares, and paranoid ideations. The activation of dopamine receptors in some way involved triggers those. Symptoms can be reduced again by lowering the levodopa dosage. But again, this will reduce the benefits that it does for treating of PD. Treatment of levodopa-induced psychosis with a first-generation antipsychotic can be problematic. These agents can decrease psychological symptoms. However, they can also intensify symptoms of PD because they block the receptors for the dopamine and the striatum. In fact, the first generation antipsychotic agents are used for schizophrenia. The biggest problem in Parkinsonism side effects refer to it as extrapyramidal symptoms. Two second-generation antipsychotics, clozapine and quetiapine, have been used successfully to manage levodopa-induced psychosis. Unlike the first-generation antipsychotic drugs, clozapine and quetiapine cause little or no blockade of dopamine receptors in the striatum, and therefore do not cause EPS, or extrapyramidal symptoms. In patients taking levodopa, these drugs can reduce psychotic symptoms without intensifying symptoms of PD. Clozapine and quetiapine are discussed in Chapter 24. Your central nervous system drugs and their effects. Levodopa may cause a number of central nervous system effects. These range from anxiety and agitation to memory and cognitive impairment. Insomnia and nightmares are common. Some patients experience problems with impulse control, resulting in behavioral changes associated with promiscuity, gambling, binge eating, or even alcohol abuse. Lastly, some other adverse effects. Levodopa may darken sweat and urine. Patients should be informed about this harmless effect. Some studies suggest that levodopa can activate malignant melanoma. However, others have failed to support this finding. Until more is known, it is important to perform a careful skin assessment of patients who are prescribed levodopa. So, drug interactions. Interactions between levodopa and other drugs. They can increase beneficial effects of levodopa and decrease beneficial effects of levodopa and increase toxicity from levodopa. So, major interactions are shown here in the following table. Several important interactions will be discussed later. So again, here's an excellent spot to hit pause so you can see the major drug interactions of levodopa. So talking on first generation antipsychotic drugs. Again, all of the first generation antipsychotic drugs, your chlorpromazine and haloperidol, block receptors for dopamine and the striatum. So as a result, they can decrease therapeutic effects of levodopa. Accordingly, concurrent use of levodopa and these medications ought to be avoided. As discussed previously, two second-generation agents, clozapine and quetiapine, they do not block dopamine receptors in the striatum, and so they can be used safely in a patient who does have PD. Monoamine oxidase inhibitors. Your levodopa can cause the hypertensive crisis if administered to an individual taking a non-selective inhibitor of a monoamine oxidase, or MAO. The mechanism is as follows. Levodopa elevates neuronal stores of dopamine and norepinephrine by promoting the synthesis of both transmitters. Because intraneuronal MAOs serve to inactivate dopamine and norepinephrine, inhibition of a MAO allows the elevated neuronal stores of these transmitters to grow even larger. Because dopamine and norepinephrine promote vasoconstriction, the release of these agents is a supernormal amounts that can lead to a massive vasoconstriction, therefore causing blood pressure to rise dangerously high. To avoid hypertensive crisis, non-selective MAO inhibitors should be withdrawn at least 2 weeks before giving levodopa. Your anticholinergic drugs. As discussed previously, excessive stimulation of cholinergic receptors contribute to the dyskinesias of PD. Therefore, by blocking these receptors, anticholinergic agents can enhance the response to levodopa. Pyridoxine. You may have read advice to limit pyridoxine or vitamin B6. It is true that pyridoxine can decrease the amount of levodopa available to reach the CNS by accelerating the decarboxylation of levodopa in the periphery. However, Because levodopa is not always combined with a carbidopa, a drug that suppresses the decarboxylase activity, this potential interaction is no longer a clinical concern. Food interactions. High protein meals can reduce therapeutic responses to levodopa. Neutral amino acids compete with levodopa for the absorption from the intestine and for transport across the blood-brain barrier. Therefore, a high protein meal can significantly reduce both the amount of levodopa absorbed and the amount transported into the brain. It has been suggested that a high protein meal could trigger an abrupt loss of effect. Accordingly, patients should be advised to spread their protein consumption evenly throughout the day. Its preparations. At one time, levodopa was available as a single drug. However, these single drug preparations have been withdrawn from the market. Levodopa is now available only in a combination preparation, either levodopa, carbidopa, or levodopa, carbidopa, and tacopone. So, let's start with the first combo drug, levodopa, carbidopa. The combination of levodopa plus carbidopa is our most effective therapy for PD. Levodopa plus carbidopa is available under three trade names: Rytary, Sinemet, and Duopa. Its mechanism of action. Carbidopa has no therapeutic effect of its own. However, carbidopa inhibits the decarboxylation of levodopa in the intestine and periphery tissue, making more levodopa available in the CNS. Carbidopa does not prevent the conversion of levodopa to dopamine by decarboxylases in the brain because carbidopa is unable to cross the blood-brain barrier. The effects of carbidopa is shown here in the following figure, which compares the fate of levodopa in the presence and absence of carbidopa. Again, as mentioned previously, in the absence of carbidopa, about 98% of levodopa is lost in the periphery, leaving only 2% available to the brain. So why is it lost? Primarily because the decarboxylases in the GI tract and peripheral tissue convert it to dopamine, which again cannot cross the blood-brain barrier. When these decarboxylases are inhibited by carbidopa, only 90% of levodopa is lost, which gives it about a 10% availability for action in the brain. So again, here is that picture version of what we just said. So, what advantages of carbidopa? The combination of carbidopa plus levodopa is superior to levodopa alone in three major ways. The first, by increasing the fraction of levodopa available for action in the CNS, carbidopa allows for the dosage of levodopa to be reduced by about 75%. In the example figure, it provides a 10 milligrams of dopamine to the brain. We must administer 500 milligrams of levodopa if carbidopa is absent, but only 100 milligrams if carbidopa is present. Second, by reducing the production of dopamine in the periphery, carbidopa reduces the cardiovascular response to levodopa as well as nausea and vomiting. And third, by causing the direct inhibition of decarboxylase, carbidopa eliminates concerns about decreasing the effects of levodopa by taking a vitamin preparation that contains pyridoxine. So, what are the advantages or disadvantages rather of carbidopa? Carbidopa has no adverse effects again on its own. Accordingly, any adverse response from carbidopa-levodopa are the result of the potentiating the effects of levodopa. When levodopa is combined with carbidopa, abnormal movements and psychiatric disturbances may occur sooner and can be more intense than if we are just taking levodopa alone. Its preparation, dose, and administration. The preparations, dosages, and administration of levodopa, carbidopa, and other drugs used in the management of PD are provided in the following table. It's an excellent spot to hit pause to familiarize yourself if you're unfamiliar with them. I'll see if it makes sense to hit pause in several spots here. So I'll leave this up for just a moment and then, oh, there we go. So two great spots to hit pause. So carbidopa alone. Again, carbidopa without levodopa is sold as Lodocin. It is available as via special request. When carbidopa is added to levodopa, carbidopa can reduce levodopa-induced nausea and vomiting. It also allows for smaller doses of levodopa to be used while promoting a more prompt response. Which brings us now to our dopamine agonists. Dopamine agonists are the first-line drugs for PD. Beneficial effects result from the direct activation of dopamine receptors in the striatum. For patients with mild to moderate symptoms, dopamine agonists are the first drug of choice. Although dopamine agonists are less effective than levodopa, they still have advantages. Specifically, in contrast to levodopa, they aren't dependent on the enzymatic conversion to become active, aren't converted to a potentially toxic metabolite, and they don't compete with dietary proteins for the uptake from the intestine or transport across the blood-brain barrier. In addition, when used long-term, dopamine agonists have a lower incidence of response failure and are less likely to cause disabling dyskinesias. However, dopamine agonists do cause serious side effects, especially hallucinations, daytime sleepiness, and postural hypotension. As a result, these drugs are usually reserved for the younger patient, who tolerate these kinds of side effects a little better than the older patient population. The dopamine agonists fall into two groups: derivatives of ergo and your non-ergo derivatives. The non-ergo derivatives, your pramipexole, ropinirole, rotigotine, and apomorphine, are highly selective for the dopamine receptors. In contrast, the ergo derivatives, your bromocriptine and your cabergoline, are less selective. In addition to activating dopamine receptors, these drugs can cause a mild blockade of serotonergic and alpha-adrenergic receptors. Because of their selectivity, the non-ergo derivatives cause fewer side effects than the ergo derivatives and hence are preferred. So here are some of the prototype drugs. Your dopaminergic drugs, your levodopa, carbidopa, pramipexole, entacapone, selegiline, and amantadine. And then you also have the centrally acting anticholinergic drugs, your benztropine. So, non-ergo derivatives, your pramipexole, ropinirole, rotigotine, and apomorphine. So, we'll start with the first. Pramipexole, also known as Mirapex, is a non-ergo dopamine receptor agonist. This drug is used alone in the early stage of PD and is combined with levodopa in its advanced stages. Mirapex binds selectively to dopamine 2 and dopamine 3 receptors. Binding to the D2 receptor underlines therapeutic effects. The significance of D3 binding is yet unknown. When used in monotherapy in early PD, Mirapex can produce significant improvement in motor performance. When combined with levodopa in advanced stages of PD, the drug can reduce fluctuations in motor control and may permit a reduction in levodopa dosage. In both cases, the maximal benefit can take several weeks to develop. Compared with levodopa, Mirapex is less effective at controlling motor symptoms of PD, but it also is less likely to cause motor fluctuations. In addition to its use in PD, Mirapex is approved for a patient with moderate to severe restless leg syndrome, a sensory motor disorder characterized by an unpleasant leg sensation that causes the urge to move the legs in an effort to ease discomfort. Symptoms are usually more intense in the evening and often disrupt sleep. People with severe restless leg syndrome experience sleep loss, daytime exhaustion, and diminished quality of life. Its pharmacokinetics. Mirapex is rapidly absorbed and plasma levels peak in 1 to 2 hours. Food reduces the speed of absorption but not its extent. Mirapex undergoes a wide distribution and achieves a high concentration in red blood cells. The drug is eliminated unchanged in the urine. Its adverse effects and interactions. Mirapex can produce a variety of adverse effects, primarily by activating dopamine receptors. The most common effect seen when pramipexole or Mirapex is used alone are nausea, dizziness, daytime somnolence, insomnia, constipation, weakness, and hallucinations. When the drug is combined with levodopa, about half the patients experience orthostatic hypotension and dyskinesias, which are not seen when the drug is used by itself. In addition, the incidence of hallucinations nearly double. A few patients have reported sleep attacks. Sleep attacks can be a real danger for people who are driving. Sleep attacks should not be equated with the normal sleepiness that occurs with a dopaminergic agent. Patients who experience a sleep attack should inform their prescriber. Mirapex has been associated with impulse control disorder, including compulsive gambling, shopping, binge eating, and hypersexuality. These behaviors are dose-related, begin about 9 months after starting Mirapex, and reverse when the drug is discontinued. Risk factors include a younger adult, a family or personal history of alcohol abuse, and a personality trait called novelty seeking, characterized by impulsivity, a quick temper, and a low threshold for boredom. Before prescribing Mirapex, clinicians should screen patients for compulsive behaviors. Cimetidine, a drug for peptic ulcer disease, can inhibit renal excretion for Mirapex, thereby increasing its blood level. Which takes us now to ropinirole. Ropinirole, also known as Requip, a non-ergodopamine agonist, is similar to Mirapex with respect to receptor specificity, mechanism of action, indication, and adverse effects. And again, similar to Mirapex, Requip is highly selective for D2 and D3 receptors, and both drugs share the same indications, PD and restless leg syndrome. In patients with PD, Requip can be used as monotherapy and as an adjunct to levodopa, in contrast to Mirapex, which is eliminated entirely by the renal excretion. Requip is eliminated by the hepatic metabolism. Some adverse effects are more common with uh, Mirapex. When Requip is used alone, the most common side effects are nausea, dizziness, somnolence, and hallucinations. Rarely, sleep attacks occur. When Requip is combined with levodopa, the most important side effects are dyskinesias, hallucinations, and postural hypotension. Note that these occur less frequently than when used with Mirapex is combined with levodopa. And like with Mirapex, Requip can promote compulsive gambling, shopping, eating, and hypersexuality. During animal testing, it indicated that Requip can cause harm to the developing fetus. Accordingly, the drug should not be used during pregnancy. Rutaglutine, or Nupro. Nupro is a non-ergodopamine agonist that is specific for selected dopamine receptors. Although the exact mechanism of action is still unknown, it is believed that rutaglutine improves dopamine transmission by activating the postsynaptic dopamine receptor in the substantia nigra. Rutaglutine is approved for the management of PD from early to advanced stages. It is also approved for the management of moderate to severe primary restless leg syndrome. Its pharmacokinetics, because first-pass metabolism of rutaglutine is extensive, oral formulations are not manufactured. It is currently available as a transdermal patch. The time from application to peak is typically in 15 to 18 hours, but may range from 4 to 27 hours. About 90% of the drug is protein bound. It also has a half-life, approximately 5 to 7 hours after the patch has been removed, and its excretion occurs both in urine and feces, though urine is about 70% and feces therefore roughly 30%. Common adverse effects. The most common adverse effects are associated with the CNS and neuromuscular system. These include a variety of sleep disorders, dizziness, headaches, dose-related hallucinations, and dose-related dyskinesias. Orthostatic hypotension and peripheral edema may occur. Nausea and vomiting are common, especially when beginning the drug. Some patients develop skin reactions at the site of application, and a hyperhidrosis may occur. Apomorphine. Apomorphine, or apokin, is another non-ergodopamine agonist approved for the acute treatment of the hypomobility during that off episode in patients with advanced PD. Unlike the other dopamine agonists, this drug is not given by mouth and is not indicated for any kind of routine PD management. When tested in patients experiencing at least 2 hours of off time a day, apomorphine produced a 62% improvement in PD rating scores, compared with the no improvement in patients who received a placebo. Benefits were sustained during 4 weeks of use. Apomorphine is a derivative of morphine, but is devoid of its typical opioid effect. Its pharmacokinetics. Apomorphine is highly lipophilic, but undergoes extensive first-pass metabolism, and therefore is ineffective when taken orally. After subcutaneous injection, the drug undergoes rapid, complete absorption. Effects begin in 10 to 20 minutes and can persist about an hour. The drug's half-life is about 40 minutes. So, its adverse effects. The most common adverse effects are site injection reactions, hallucinations, yawning, drowsiness, dyskinesias, rhinorrhea, nausea, and vomiting. During the clinical trial, there was a 4% incidence of serious cardiovascular events, angina, myocardial infarction, cardiac arrest, and sudden death. Postural hypotension and fainting occurred in 2% of patients. So, like other dopamine agonists, apomorphine poses a risk for daytime sleep attacks. In addition, apomorphine can promote hypersexuality and enhanced erections. Rarely, apomorphine caused any kind of priapisms, but there was sustained painful erections, possibly requiring surgical intervention. When combined with an antiemetic to prevent the nausea vomiting during clinical trials, nearly all patients were treated with an antiemetic, starting 3 days prior to the first dose of apomorphine. The antiemetic chosen was Tigan. 2 classes of antiemetics cannot be used, which are your serotonin receptor antagonists, so Sofran, and dopamine receptor antagonists, such as your prochlorperazine or compazine. Your serotonin receptor antagonists will increase the risk for postural hypotension while having no effect on the nausea, and your dopamine receptor antagonists will decrease the effects of apomorphine and most other drugs for PD. About half the trial participants discontinued the antiemetic at some point, but were continued taking apomorphine. So those were all your non-ergo derivatives. Now let's talk about the ergo derivatives, your bromocriptine and your cabergoline. So the 2 derivatives, as mentioned above, are used to manage PD. Bromocriptine is approved for PD, whereas cabergoline is not. These drugs are poorly tolerated, so their use is very limited. The side effect profile of the ergo derivatives differ from that of the non-ergo agents because, in addition to activating dopamine receptors, the ergo drugs cause a mild blockade of serotonergic and alpha-adrenergic receptors. So, let's start off with the first one. Bromocriptine, also known as cycloset, is a derivative of ergo, is a direct-acting dopamine agonist. Beneficial effects derive from activating dopamine receptors in the striatum. Responses are equivalent to those seen with pramipexole and ropinirole. Bromocriptine is used alone in early PD and in combination with levodopa in advanced PD. When combined with levodopa, bromocriptine can prolong therapeutic responses and reduce motor fluctuation. In addition, because bromocriptine allows the dosage of levodopa to be reduced, the incidence of levodopa-induced dyskinesias may be reduced too. Adverse effects are dose-dependent and are seen in 30 to 50% of patients. Nausea was the most common. The most common dose-limiting effect are psychological reactions, such as your confusion, nightmares, agitation, hallucinations, and paranoid delusions. These occur in about 30% of patients and are most likely when the dosage is high. Like levodopa, your bromocriptine can cause dyskinesias and postural hypotension. They can also cause retroperitoneal fibrosis, pulmonary infiltrates, and a Raynaud-like phenomenon, as well as erythromyalgias. In addition, ergoderivatives have been associated with valvular heart disease. The probable cause is the activation of the serotonin receptors on the heart valves. Which brings us to the other medication, cabergoline. Cabergoline, a drug approved for the treatment of the hyperprolactinemic disorders, is used occasionally in PD, although it's not approved by the FDA for this disorder. According to the AAN guidelines, the drug is a possible effective for improving the off times during levodopa therapy. However, the supporting evidence is considered weak. Therefore, carbagoline is rarely used unless other management attempts have failed. Common side effects are headaches, dizziness, nausea, and weakness. A more concerning adverse effect is the development of a cardiac valve regurgitation and the subsequent development of heart failure. Pulmonary and pericardial fibrosis also have occurred. Which brings us to the catechol O-methyltransferase inhibitors, or 2-COMT inhibitors, which are available, again, entacapone and tolcapone. Both drugs benefits derive from inhibiting the metabolism of levodopa in the periphery. These drugs have no direct therapeutic effect on their own. Again, entacapone is safer and more effective than tolcapone and is therefore the preferred medication. So we'll start with that one. Entacapone, also known as COMT10, is a selective, reversible inhibitor of COMT, indicated only for the use with levodopa. Like carbidopa, your COMT10 inhibits metabolism of levodopa in the intestines and peripheral tissues. However, the drug inhibits different enzymes. Carbidopa inhibits your decarboxylases, whereas entacapone inhibits COMT. By inhibiting COMT, entacapone prolongs the plasma half-life of levodopa and therefore prolongs the time that levodopa is available in the brain. In addition, entacapone increases levodopa availability by a second mechanism. By inhibiting COMT, entacapone decreases the production of levodopa metabolites that would compete with levodopa for the transport across the blood-brain barrier. In clinical trials, entacapone increased the half-life of levodopa by 50 to 75%, and thereby caused levodopa blood levels to be more stable and sustained. As a result, that wearing off was delayed and the on times were extended. Entacapone may also permit a reduction in levodopa use. So, its pharmacokinetics. Entacapone is rapidly absorbed and reaches peak levels in 2 hours. Elimination is by the hepatic metabolism, followed by the excretion in the feces and urine. Again, the plasma half-life is about 1.5 to 3.5 hours. It does come with adverse effects, which result from the increased levodopa level, although some are caused by the entacapone itself. By again increasing levodopa levels, entacapone can cause dyskinesias, orthostatic hypotension, nausea, hallucinations, sleep disturbances, and impulse control disorders. These can be managed by decreasing levodopa. Entacapone should not be stopped abruptly. Doing so can result in significant worsening of symptoms. The medication itself, however, has fewer adverse effects, and the most common are vomiting, diarrhea, constipation, and a yellow-orange discoloration in the urine. Its drug interaction. Because it inhibits COMT, entacapone can, in theory, increase levels of drugs metabolized by COMT. In addition to levodopa, these include methyldopa, dobutamine, and isoproterenol. If entacapone is combined with these drugs, the reduction of their dosages may be needed. Which brings us to tolcapone. Tolcapone, also known as Tasmar, is another COMT inhibitor, used only in conjunction with levodopa, and only a safer agent are ineffective or inappropriate is when it would be utilized. As with entacapone, benefits derived by inhibiting levodopa metabolism in the periphery, which prolongs levodopa availability. When given to patients taking levodopa, tolcapone improves motor function and may allow a reduction in levodopa dosage. For many patients, the drug reduces the wearing off effect that can occur with levodopa, thereby extending levodopa's on time by as much as 2.9 hours a day. Unfortunately, although tolcapone is effective, it is potentially dangerous. Death from liver failure have occurred. Because it causes serious risk, tolcapone should be reserved for a patient who cannot be treated or treated adequately with other medications. When tolcapone is used, treatment should be limited to 3 weeks in the absence of a beneficial response. Its pharmacokinetics. Tolcapone is well absorbed after oral dosing. Its plasma levels peak in 2 hours. In the blood, tolcapone is highly bound, 99.9%, to plasma protein. The drug undergoes extensive hepatic metabolism, followed by renal excretion, and again, and a half-life of 2 to 3 hours. So, adverse effects. Because of its high bind to your plasma proteins and heavy extensive hepatic metabolism, liver failure. Tolcapone can cause severe hepatocellular injury, which is sometimes fatal. Because of this risk, a black box warning is mandated by the FDA. Before treatment, patients should be fully apprised of the risk. They also should be informed about signs of emergent liver dysfunction, persistent nausea, fatigue, lethargy, anorexia, jaundice, and dark urine, and be instructed to report these immediately. Patients with pre-existing liver dysfunction shouldn't even begin taking this medication. If liver injury is diagnosed, the medication should never be used again. So, the black box warning on it, therefore. Tolcapone increases the risk for hepatotoxicity. Liver injury and failure may be fatal. Close monitoring is required. The medication needs to be discontinued if clinical signs or symptoms of liver injury occur, or if the AST or ALT elevation is twice the upper range of normal. Your lab monitoring of liver enzymes is required. Test for serum alanine aminotransferase, your ALT, and your aspartate aminotransferase, AST, should be conducted before treatment and then throughout treatment as follows: at least every 2 weeks for the first year, and then every 4 weeks for the next 6 months, and then every 8 weeks thereafter. If the ALT and AST levels exceed the upper limit of normal, the medication needs to be stopped and discontinued. Monitoring may not prevent liver injury, but early detection and immediate drug withdrawal may minimize the harm. Other adverse effects. By increasing the availability of levodopa, tolcapone can intensify levodopa-related effects, especially your dyskinesias, your orthostatic hypotension, nausea, hallucination, sleep disturbances, and impulse control disorders. A reduction in levodopa dosage may be required. Tolcapone can cause diarrhea, hematuria, and a yellow-orange discoloration of the urine. Abrupt withdrawal of the medication can also produce symptoms that resemble a neuroleptic malignant syndrome, fever, muscular rigidity, and altered consciousness. In rats, large doses have caused renal tubular necrosis and tumors of the kidneys and uterus. Which brings us to the next combo drug, levodopa, carbidopa, and tacopone. These medications are now available in a fixed-dose combination also known as Stalevo. As discussed earlier, both carbidopa and entacapone inhibit the enzymatic degradation of levodopa and therefore enhance its therapeutic effect. The triple combination is more convenient than taking a singular medication, and its costs are a little less too. Unfortunately, Stalevo is available only in an immediate release tablet and only in a specific strength. Patients who need more flexibility in their regimen cannot be treated with Stalevo, nor can patients who require a sustained release formula take this medication. Your monoamine oxidase B inhibitors, your MAO-B inhibitors, your selegiline and rasagiline are considered first-line drugs for PD, even though their benefits are only considered modest. When combined with levodopa, they can reduce the wearing off effect. So let's start with the first, selegiline. Selegiline, also known as deprenyl, was the first MAO-B inhibitor approved for the use of PD. The drug may be used alone or in combination with levodopa. In both cases, your improvement in your motor function is considered modest. There is some evidence suggesting that selegiline may delay neurodegeneration and therefore can delay the disease progression. However, conclusive proof of neuroprotection is still lacking. Nonetheless, current guidelines suggest trying selegiline in a newly diagnosed patient, just in case the drug does confer some protection. Its action and use. Selegiline causes a selective, irreversible inhibition of the MAO-B, the enzyme that inactivates dopamine in the striatum. Another form of MAO, known as monoamine oxidase, A, inactivates the norepinephrine and serotonin. As discussed in Chapter 25, non-selective inhibitors of MAO are used to treat depression and pose a risk for hypertensive crisis and side effects. Because selegiline is a selective inhibitor of MAO-B, the drug is not an antidepressant and at recommended doses poses little or no risk for the hypertensive crisis. Selegiline appears to benefit patients with PD in two ways. First, when used as an adjunct to levodopa, selegiline can suppress destruction of dopamine derived from levodopa. The mechanism is inhibition of MAO-B. By helping preserve dopamine, selegiline can prolong the effect of levodopa and can therefore decrease fluctuations in motor control. Unfortunately, these benefits decline dramatically within 12 to 24 months. In addition to preserving the dopamine, there is some hope that selegiline may delay the progression of PD. When used early in the disease, selegiline can delay the need for levodopa. This may reflect a delay in the progression of the disease, or it may simply reflect direct symptomatic relief from selegiline itself. If selegiline does slow the progression of PD, what might be the mechanism? In experimental animals, selegiline can prevent development of Parkinsonism after the exposure of a 1-methyl-4-phenyl-12,3-6 tetrahydropyridine, or MPTP, a neurotoxin that causes selective degeneration of dopaminergic neurons. Neuronal degeneration is not caused by MPTP itself, but rather by a toxic metabolite. Formation of this metabolite is catalyzed by the MAO-B. By inhibiting MAO-B, the selegiline prevents the formation of toxic metabolite and therefore protects against neuronal injury. It also delays the progression of PD. This mechanism can be the explanation of the effect. That is, just as selegiline protects animals by suppressing the formation of neurotoxic metabolites of MPTP, the drug may delay the progression of PD by suppressing the formation of neurotoxic metabolites of an as yet unidentified compound. So, the pharmacokinetic for the treatment of PD, selegiline is available in two oral formulations, tablets and capsules, and is orally disintegrating tablets. So, in tablets and capsules, they both undergo rapid GI absorption, travel to the brain, and quickly penetrate the blood-brain barrier. Irreversible inhibition of the MAO-B follows. Selegiline undergoes hepatic metabolism, followed by a renal excretion. Two metabolites, one amphetamine and one methamphetamine, are CNS stimulants. These metabolites, which do not appear to have a therapeutic effect, can be harmful. Because selegiline causes irreversible inhibition of MAO-B, effects persist until more MAO-B can be synthesized. The oral disintegrating tablet, unlike the selegiline in tablets and capsules, which are absorbed in the GI tract, the disintegrating tablet is absorbed through the oral mucosa. As a result, the bioavailability is higher than with the tablets and capsules, and therefore doses can be lower. Otherwise, pharmacokinetics are identical with the tablets. Its adverse effects. When the medication is used alone, the principal adverse effect is insomnia, presumably because of CNS excitation by the amphetamine and methamphetamine. Insomnia can be minimized by administering the last daily dose no later than noon. Other adverse effects include orthostatic hypotension, dizziness, and GI symptoms. Patients taking selegiline ODTs may experience irritation of the buccal mucosa. Hypertensive crisis. Although selegiline is selective for MAO-B, high doses can inhibit MAO-A, which create a risk for hypertensive crisis, especially in a younger patient. As discussed in Chapter 25, when a patient is taking a MAO inhibitor, hypertensive crisis can be triggered by ingesting foods that contain tyramine and by taking certain drugs, including sympathomimetics. Accordingly, patients should be instructed to avoid these foods and drugs, both while taking selegiline and for at least 2 weeks after stopping. So, its black box warning. Antidepressants are associated with an increased risk for suicide in patients younger than the age of 24. Selegiline, an antidepressant well known as a drug for PD, is included in this warning. It carries an increased risk also for hypertensive crisis in younger patients and is contraindicated in children younger than the age of 12. So, its drug interactions. Levodopa. When used with levodopa, selegiline can intensify adverse responses to levodopa-derived dopamine. These reactions, orthostatic hypotension, dyskinesias, and psychological disturbances, can be reduced by decreasing the dose of levodopa. Meperidine, like other non-selective MAO inhibitors, can cause a dangerous interaction with meperidine, also known as Demerol. Symptoms include stupor, rigidity, agitation, and hyperthermia, so this combination needs to be avoided. SSRIs, or selective serotonin reuptake inhibitors. Selegiline should not be combined with an SSRI, such as Prozac. The combination of a MAO-B inhibitor plus an SSRI can cause a fatal serotonin syndrome. Accordingly, SSRIs should be withdrawn at least 5 weeks before giving selegiline. Razagiline, also known as Azilect, is another MAO-B inhibitor for PD. Similar to selegiline, razagiline is a selective, irreversible inhibitor of MAO-B. Benefits derive from preserving dopamine in the brain. This drug is approved for initial monotherapy of PD and for combination with the use of levodopa. Razagiline is similar to selegiline in most regards. As with selegiline, benefits are considered modest. The drugs differ primarily in that razagiline is not converted to amphetamine or methamphetamine, so its pharmacokinetics. Razagiline is rapidly absorbed with a bioavailability of 36%. In the liver, the drug undergoes nearly complete metabolism by the CYP1A2. Hepatic impairment: the drugs that inhibit CYP1A2 will delay metabolism of rasagiline, causing blood levels of the drug to rise. This drug should be decreased by half in mild hepatic impairments. Patients with moderate to severe hepatic impairments should not use this medication. In contrast to selegiline, razagiline is not metabolized to amphetamine derivatives. Its excretion is primarily through the urine and feces. The plasma half-life is about 3 hours. However, because razagiline causes irreversible inhibition of MAO-B, clinical effects persist until new MAO-B is synthesized. Its adverse effects: when used in monotherapy, razagiline is generally well tolerated. The most common side effects include headaches, arthralgias, dyspepsias, depression, and flu-like symptoms. Unlike selegiline, razagiline does not cause insomnia. When razagiline is combined with levodopa, side effects increase. The most common addition are your dyskinesias, accidental injury, nausea, orthostatic hypotension, constipation, weight loss, and hallucinations. Razagiline may pose a risk for hypertensive crisis similar to selegiline, owing again to the inhibition of the MAO-A, and therefore patients should be instructed to avoid again the tyramine-containing foods and certain drugs including your sympathomimetic agents. Razagiline may increase the risk for malignant melanoma, a potentially deadly cancer of the skin. Periodic monitoring of the skin is recommended. So, drug and food interactions. So, razagiline has the potential to interact adversely with several different drugs. So, we'll talk about some of the following. The first, levodopa. Razagiline can intensify adverse responses to levodopa-derived dopamine. If the patient starts to develop a dopaminergic side effect, such as dyskinesias or hallucinations, reducing the dosage of levodopa, not razagiline, should be considered. Your CYP1A2 inhibitors. Again, blood levels of razagiline can be raised by medications such as your ciprofloxacin and other drugs that inhibit CYP1A2. The hepatic enzyme that inactivates razagiline. For patients taking these medications, a daily dosage should be reduced. And drugs and foods that are contraindicated. Again, MAO inhibitors. Combining razagiline with other MAO inhibitors increases the risk for hypertensive crisis. Again, at least 2 weeks should separate the use of these drugs. Sympathomimetics. These drugs are your amphetamines, ephedrine, phenylephrine, and pseudoephedrine, or pseudoephedrine. All can raise the risk for hypertensive crisis and again must be avoided. Your tyramine-containing foods. These agents again raise the risk for hypertensive crisis. Antidepressants. The big ones are your mirtazapine or SSRIs and your tricyclic antidepressants. All can raise the risk for hyperpyrexia and death. These drugs should be discontinued at least 2 weeks before starting razagiline. Your fluoxetine or SSRI should be discontinued at least 5 weeks prior to starting razagiline. Your analgesics. Combining razagiline and meperidine, methadone, or tramadol can pose a risk for serious reactions including coma, respiratory depression, convulsions, hypertension, hypotension, and death. At least 2 weeks should separate these medications. Dextromethorphan. Combining razagiline with dextromethorphan may pose a risk for brief episodes of psychosis and bizarre behavior. And lastly, your cyclobenzaprine. This drug is structurally related to the tricyclic antidepressant and therefore should be avoided. Amantadine. Speaking on amantadine, it was formerly known as Simitrel, was developed as an antiviral agent and was later found effective in PD. Possible mechanisms include the inhibition of dopamine uptake, stimulation of dopamine release, and the blockade of a cholinergic receptor, antagonism of the N-methyl D-aspartate, your NMDA receptors, and blockade of glutamate receptors. Responses develop rapidly, often within 2 to 3 days, but are much less profound than with levodopa or the dopamine agonists. Furthermore, responses may begin to diminish within 3 to 6 months. Accordingly, amantadine is not considered a first-line agent. However, the drug may be helpful for managing dyskinesias caused by levodopa. So, adverse effects. Amantadine can cause adverse CNS effects, confusion, lightheadedness, and anxiety, and peripheral effects that are thought to result from muscarinic blockade. All of these are generally mild when amantadine is used alone. However, if amantadine is combined with an anticholinergic agent, both the CNS and peripheral responses will be intensified. Patients taking amantadine for at least 1 month or longer often develop livedo reticularis, a condition characterized by mottled discoloration of the skin. Livedo reticularis is benign and gradually subsides after amantadine withdrawal. Amantadine often loses effectiveness after several months. Its effects diminish. They can be restored by increasing the dosage or by interrupting treatment for several weeks. Your centrally acting anticholinergic drugs. So, anticholinergic drugs have been used in PD since 1867, making them the oldest medications for the disease. These drugs alleviate symptoms by blocking muscarinic receptors in the striatum, therefore improving the balance between dopamine and acetylcholine. Anticholinergic drugs can reduce tremor and possibly rigidity, but not bradykinesia. These drugs are less effective than levodopa or the dopamine agonists, but are better tolerated. Today, anticholinergics are used as second-line therapy for tremor. They are the most appropriate for younger patients with mild symptoms. Anticholinergics are generally avoided in older patients who are intolerant of CNS side effects. Although the anticholinergic drugs used today are somewhat selective for cholinergic receptors in the CNS, they can also block cholinergic receptors in the periphery. As a result, they can cause dry mouth, blurred vision, photophobia, urinary retention, constipation, and tachycardia. These effects are usually dose-limiting. Blockade of cholinergic receptors in the eye may precipitate or aggravate glaucoma. Accordingly, intraocular pressure should be measured periodically. Peripheral anticholinergic effects are discussed in Chapter 12. The anticholinergic agents used most often are benztropine or cogentin and trihexyphenidyl, formerly available as Artane. Providers need to be aware that the anticholinergic drugs are discontinued abruptly. Symptoms of Parkinsonism may be intensified. Your non-motor symptoms and their management. In addition to experiencing characteristics of motor symptoms, 90% of patients with PD develop non-motor symptoms, notably autonomic disturbances, sleep disturbances, depression, dementia, and psychosis. Management is addressed in 2 evidence-based AAN guidelines. So the practice parameter, the evaluation of and treatment of depression, psychosis, and dementia, and the treatment of non-motor symptoms of Parkinson's disease. Your autonomic system or symptoms. Disruption of the autonomic function can produce a variety of symptoms, including constipation, urinary incontinence, drooling, orthostatic hypotension, cold intolerance, and erectile dysfunction. The intensity of these symptoms increase in parallel with the intensity of motor symptoms. Erectile functions can be managed with sildenafil or Viagra, and other inhibitors of type 5 phosphodiesterases, which we'll discuss more in Chapter 51. Orthostatic hypotension can be improved by increase of salt and fluid, and possibly by taking a fludrocortisone, a mineralocorticoid. Urinary incontinence may be improved with oxybutynin and other peripherally acting anticholinergic drugs that are discussed in Chapter 12. Constipation can be managed by getting regular exercise and maintaining adequate intake of fluid and fibers. However, polyethylene glycol, an osmotic laxative or stool softener, eudocosate may also be tried, which is discussed in Chapter 63. Sleep disturbances. PD is associated with excessive daytime sleepiness, periodic limb movements of sleep, and insomnia. Your EDS, or your excessive daytime sleepiness, may respond to modafinil, or a non-amphetamine CNS stimulant, which we'll discuss further in Chapter 29. For PLMS, or periodic limb movement of sleep, levodopa-carbidopa should be considered. The non-ergodopamine agonist, pramipexole and ropinirole, may also assist in that. Insomnia may be improved by levodopa-carbidopa and melatonin, which we'll discuss more in Chapter 27. Levodopa-carbidopa helps by reducing motor symptoms that can impair sleep. Melatonin helps by making people feel like they are sleeping better, even though objective measures of sleep quality may not improve. Depression. About 50% of PD patients develop depression, partly in reaction to having a debilitating disease, and partly due to the disease process itself. Accordingly to the AAN guideline, only one drug, amitriptyline, has been approved effective in these patients. Unfortunately, amitriptyline, a tricyclic antidepressant, has anticholinergic effects that can exacerbate dementia and anti-adrenergic effects that can exacerbate orthostatic hypotension. So data for other antidepressants, including SSRIs and bupropion, are insufficient to prove or disprove efficacy in PD. Dementia. Dementia occurs in 40% of PD patients. The AAN guideline recommends considering treatment with two drugs, donepezil and rivastigmine. Both drugs are cholinesterase inhibitors developed for Alzheimer's disease, which we'll discuss in Chapter 18. In patients with PD, these drugs can produce a modest improvement in cognitive function without causing significant worsening of motor symptoms, even though these drugs increase availability of acetylcholine at central synapses. Psychosis. In patients with PD, psychosis is usually caused by the drugs taken to control motor symptoms. Most of these drugs, levodopa, dopamine agonists, amantadine, and anticholinergic drugs, all can cause hallucinations. Therefore, if psychosis starts to develop, dopamine agonists, amantadine, and anticholinergic drugs should be withdrawn, and the dosage of levodopa should be reduced to the lowest effective amount. If antipsychotic medications are needed, first-generation antipsychotics should be avoided because all of these drugs block receptors for dopamine and therefore intensify motor symptoms. Accordingly, the AAN guideline recommends considering two second-generation antipsychotics, clozapine and quetiapine. Because clozapine can cause agranulocytosis, many clinicians prefer quetiapine. The guidelines recommend against routine use of olanzapine, another second-generation agent. The antipsychotic drugs will be discussed in more detail in Chapter 24. So, prescribing and monitoring considerations. For levodopa-carbidopa, or Sinemet, the goal of treatment is to improve the patient's ability to carry out your activities of daily living. Levodopa does not cure PD or delay its progression. Assessing motor symptoms, your bradykinesia, akinesia, postural instability, tremor, rigidity, and the extent to which they interfere with ADLs need to be part of the baseline data. Identifying your high-risk patients. Because some studies suggest that levodopa MAO inhibitors can activate malignant melanomas for patients that are taking these drugs, it's important to perform a careful skin assessment and to monitor for skin changes. Exercise caution in patients with any kind of cardiac disease and psychiatric disorders, and in patients taking already selective MAO-B inhibitors. Administration concerns. Motor symptoms may make self-medication challenging. The patient may require assistive devices for opening medication containers. Request pharmacists to avoid using child-proof containers, and when available and appropriate, involve family members in medicating out patients. Ongoing monitoring and interventions. The evaluating therapeutic effects. Again, you want to evaluate for improvements in ADLs and for the reduction in bradykinias, postural instabilities, tremors, and rigidity. Managing that acute loss of effect. Again, oftentimes can be reduced by combining levodopa-carbidopa with a dopamine agonist, a COMT inhibitor, or a MAO-B inhibitor. Notify the prescribing specialist of any kind of increasing issues. Minimizing adverse effects. Again, the big ones, nausea and vomiting. Recommend that the medication be taken with food if nausea and vomiting is a problem. Your dyskinesias. Giving amantadine may help with dyskinesias. Consult the prescribing specialist about a possible reduction, therefore, in dosage. Orthostatic hypotension and dysrhythmias. Monitor orthostatic vital signs at each clinic visit. If the patient reports palpitations or dysrhythmias are suspected, an EKG or monitoring may be indicated. Notify the prescriber of the development of new dysrhythmias. Psychosis. Notify the prescriber of psychosis or other mental status changes. The prescriber may recommend treatment with clozapine or quetiapine. Minimizing adverse interactions. Your first-generation antipsychotic drugs. These can block responses to levodopa and should be avoided. Your second-generation antipsychotics, clozapine and quetiapine, can be used safely. Your MAO inhibitors. The concurrent use of levodopa and a non-selective MAO inhibitor can produce severe hypertension. Withdraw non-selective MAO inhibitors again at least 2 weeks before initiating levodopa. Anticholinergic drugs. These can enhance therapeutic responses to levodopa, but they can also increase the risk for adverse psychiatric effects. And your high-protein meals. Amino acids compete with levodopa for absorption from the intestine and the transport across the blood-brain barrier. Dopamine agonists. The therapeutic goal. The goal of treatment is to improve the patient's ability to carry out activities of daily living. Your dopamine agonists do not cure PD or delay its progression. Apomorphine is reserved for rescue treatment of hypomobility during OFF episodes in patients with advanced PD. Its baseline data, therefore. Assessing motor symptoms. Your bradykinias, achonesias, postural instability, tremor, rigidity, and the extent to which these interfere with ADLs. Identifying high-risk patients. Use of all dopamine agonists with caution in the older adult patients and in those with psychiatric disorders. The use of pramipexole with caution in patients with kidney dysfunction. Avoid ropinirole during pregnancy, and the use of both of these with cautions who have patients who are prone to compulsive behaviors. Administration concerns. Again, Parkinsonism may make self-medication difficult. Assistive devices may be needed. If appropriate, involve family members in medicating outpatients. To minimize adverse effects, dosage should be low initially and then gradually increase. Reduce dosage of pramipexole in patients with significant renal dysfunction. ongoing evaluation and intervention, therefore. Evaluate for improvement in ADLs and for reductions in bradykinesias, postural instability, tremor, and rigidity. Minimizing adverse effects, again, your nausea and vomiting, and orthostatic hypotension are addressed through teaching. If symptoms persist or if other complications occur, the prescriber should be notified and medication adjustment may be necessary. So, patient education on dopamine agonists. It's important that we inform the patient of several things. Inform the patient that nausea, vomiting can be reduced by taking oral dopamine agonists with food. You want to take the medication and notify the prescriber if nausea and vomiting persist or become severe. Patients who are taking apomorphine may pre-treat with a trimethylbenzamide or Tigan, an antiemetic. Patients should know about symptoms of orthostatic hypotension and be advised to sit or lie down if these begin to occur. Advise patients to move slowly when sitting up or standing up to help prevent that orthostatic hypotension. Explain about the potential for movement disorders. Again, your tremor, dystonic movements, and twitching. And to notify the prescriber if they develop. Forewarn your patient that dopamine agonists can cause hallucinations, especially in the elderly. Warn patients that pramipexole, ropinirole, rotogitine, and apomorphine all can cause sleep attacks, and if an attack occurs, patients should inform the prescriber and avoid potentially hazard activities, especially driving. Inform patients of childbearing age that the medication ropinirole may harm the developing fetus, and that it is known to cause birth defects. Finally, fetal injury. If pregnancy occurs and will be continued, switching to a dopamine agonist other than ropinirole is advised, again because of the above statement. And lastly, impulse control disorders. Pramipexole and ropinirole may induce compulsive, self-rewarding behaviors, including compulsive gambling, eating, shopping, and hypersexuality. Risk factors include relative youth, and a family or personal history of alcohol abuse and novelty-seeking personality. Before prescribing these drugs, clinicians should screen their patient for compulsive behaviors. And that concludes our chapter here for today. I thank you for listening as always, and I'll see you at the next chapter. Till then, thank you and have a good day.